Welcome, everyone. We are so thrilled to have you all join us today for our learning community for family leaders titled On the Front Lines, Families and Family-Run Organizations Responding to the Opioid Epidemic. My name is Melissa Pearson, and I am a project coordinator with FREDLA, the Family-Run Executive Director Leadership Association. Many of you have probably joined us before for one of our learning communities, but for those of you who have not, FREDLA is a national organization whose mission is to support the leadership and organizational capacity of family-run organizations across the country. We are a partner in the National Training and Technical Assistance Network through the University of Maryland and serve as the family leadership hub for system of care and non-system of care communities and states. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. We are so blessed today to have two amazing family leaders co-present on this topic. Trish Todd, who is from the Maryland Coalition of Families in Maryland, and Shannon Crossbear from the National Family Dialogue and Change Matrix. Each of them will provide a more full introduction when they begin their presentation. Before we begin with the presentation today, I want to quickly review our agenda. We'll begin by providing an overview of the current state of the opioid epidemic in America. Then we will hear about two different models that provide peer-parent support for families whose youth and young adults are impacted by a substance use disorder. We'll discuss some ways families and family-run organizations can respond to the opioid epidemic, and we will conclude today's call with time for question and answers and some time for peer sharing. If you have questions during today's presentation, feel free to type them into the chat box. If your questions are not answered during the presentation, we will share them with the presenters during the Q&A portion at the end of the call. So let's get started. This is an infographic from SAMHSA, and it does an excellent job laying out the stark reality of the opioid epidemic our country is currently facing. As of 2016, 116 people lost their lives each and every day to opioid-related overdoses. 11.5 million people misused prescription opioids, and 2.1 million had a diagnosable opioid use disorder. If substance use disorders were a state, its population would be the fourth largest in the United States. And youth and young adults are the fastest growing population becoming addicted to opioids. So as you can see, the opioid addiction and misuse in the United States is a staggering issue. This is one of the reasons we felt a need to focus on this topic for this learning community. The other reason is that we believe family leaders and family-run organizations have the programming and expertise to serve as a vital resource for families, youth, young adults, service providers and organizations, communities, and states. In 2017, the Department of Health and Human Services declared a public health emergency, which allows some grant money to be used to combat opioid abuse, permits the hiring of specialists to tackle the crisis, and expands the use of telemedicine services to treat people in rural areas ravaged by opioid use, where doctors are often in short supply. The Department of Health and Human Services also announced a 5-point strategy for combating the opioid crisis. The key areas prioritized were improving access to treatment and recovery services, promoting use of overdose reversing drugs, strengthening our understanding of the epidemic through better public health surveillance, which includes education and awareness activities, providing support for cutting-edge research on pain and addiction, and advancing better practices for pain management. Several of these priority areas align closely with the activities of family-run organizations and parent peer support programs. In just a moment, you will hear how family organizations and family leaders are developing programming delivered by those with lived experience that supports the priority areas and promotes what we know works for individuals with opioid addiction and substance use disorders. These parent-to-parent models improve access to treatment and recovery services by providing systems navigation, support, and education to families of youth and young adults. They strengthen the understanding of families, youth, and young adults about what addiction and recovery means, how addiction is a brain disorder and not a moral failing, and help contribute to the research base about what works for youth, young adults, and families impacted by the opioid epidemic and substance use disorders. We know that medication-assisted treatment is the gold standard when it comes to treatment of opioid addiction. That, coupled with behavioral counseling, evaluations for co-occurring mental health conditions, and long-term follow-up and support. Unfortunately, as you can see in these numbers, very few people are actually able to access this kind of treatment or support. According to SAMHSA's National Survey on Drug Use and Health, 22.5 million people aged 12 and older needed treatment for an illicit drug or alcohol problem in 2014. Of those 22 million, only 4.2 million received any treatment in that same year. And of those, 2.6 million received treatment at a specialty treatment program, which would have included things such as medication-assisted treatment, behavioral counseling, or long-term follow-up and support. And as of 2016, we surpassed 42,000 lives lost to the opioid epidemic, lowering the life expectancy for Americans overall. I'm sure you would all agree there is a great deal needing to be done to respond to this public health emergency. And we believe family-run organizations and parent peer support programs are perfectly positioned to step into the gap and become one of the critical interventions and supports that make a difference in helping youth, young adults, and families impacted by this opioid epidemic. I'm now going to turn it over to Shannon Crossbear from Change Matrix and the National Family Dialogue. Shannon?
Thanks. Thanks, Melissa. I always, even though I've heard those statistics many, many times, I'm always taken aback by, how pervasive this issue is. And so I just want to welcome everybody spending their afternoon with us to have this discussion. My name is Shannon Crossbear. I think first and foremost, I'm a parent of children who are impacted by substance use disorders. I have one son who is in long-term recovery. I have one son who is no longer on this earth walk and is part of those statistics of lives lost. And I have another son who still struggles with substance use, and I'm hopeful that he can have a good outcome. So I think why we're having this conversation, I think that Melissa pretty much laid it out for us in terms of the larger conversation and the epidemic. I remember one of the statistics she talked about from 2016 was that we were experiencing 116 deaths a day as a result of opioids. That was in 2016, and now we're in 2018, and I'm sorry to report it's not going in the right direction. So we are now experiencing 149 deaths a day. So we've gone up in this epidemic, and we can see that those things are, that's the whole nature of an epidemic. And so we need to have this conversation about how we can do things differently and what the opportunities that we have are to create change. And I always like to start with just a picture of my family because I like them. And I think it's it helps to remind us sometimes when we're on calls like these, and they're a part of the work that we're doing in the world, but sometimes we can get it detached from the actual faces and families and individuals' lives that we're talking about. And so I always try to keep that in mind, that these are families, these are people that we love and care about, and this is impacting all of us. And I say that because I recently saw something that was saying that we're now at 1 in 4 of us will be impacted in some way by a substance use disorder in our lifetime. If not us as an individual, then somebody, one of our relatives or a loved one, somebody that we care about or know about in our community. So that's huge. And it's really important that, we recognize that, I think Melissa said it, we all play a role when we have an epidemic. What it means is that it affects all of our sectors, right? All of our, whether it be education, our welfare, our health, our economics, all of it gets affected, and we all need to be participating in how we address that. So a few years back, Substance Abuse and Mental Health Services, CSAT, the Center for Substance Abuse Treatment, had an opportunity to bring families together to talk about adolescents, specifically about adolescent substance use disorders. And when they brought families together, there was a great opportunity to have that discussion about what was working, what was not working, and what maybe we needed to start doing differently. The other thing that happened is that, of course, anytime you get a group of families together, they're going to visit with each other and share their stories, and that's what happened. And what they found out was that there were some pockets of excellence in terms of the work that was being done out there by families in communities across the nation. But there was no opportunity to share that in kind of a national way. And so after that meeting, there was a network that was developed, and the National Family Dialogue, and its mission was to really unite those voices across the nation to help improve and sustain the substance abuse treatment and recovery systems, so that all the youth would be able, and their families would have that complete access to affordable, effective treatment and recovery services. And so that's been in existence now since 2009, and really it's providing more of a opportunity, I think, than anything else for those pockets of excellence to get connected, and for things when things are really working well, to develop, and when they're not, to develop a unified voice within the treatment and recovery system. And also one of the things, of course, that we discovered along the way was how it wasn't just within the substance abuse treatment facilities or substance abuse treatment world that we needed to exert that voice, but also in other child-serving systems. So we really saw how important it was for this need for the cross-systems collaboration. And I can see by the participants' names and that there are many of you that understand this very well that are on the phone, but really about how different it is for families to try to navigate those different child-serving systems, and what kind of experience one needs in order to do that. So my co-director of the National Family Dialogue, Sharon Smith-Lagore, and I had an experience early on. I had come into services with my family through the mental health world initially, and she had come into services with her family through the substance use world. And we were both working on a project at the time called the Statewide Infrastructure Grants that were looking to try to bring together in states the mental health and the substance use divisions into one division under behavioral health. And we came in kind of representing that family voice to help do some technical assistance to those states that had those awards. And as we got to know each other, and of course as our lives unfolded, it became necessary for me to start to learn how to access substance use treatment, of which all of my training, everything I knew about navigating the mental health system did not apply, period. And as life would have it, Sharon had an experience where she needed to navigate the mental health system, and of course she found the same thing was true. It was the language, it was the roles that families played, everything was different about those child-serving systems. And so we really became necessary that we could exchange and kind of share information. You know, it was like I needed to know what questions to ask, and she needed to know what terminology to use when she was talking about medication or other things within the mental health field. And so we had to learn new processes and rules and requirements. And so, you know, and in that process, of course, what would happen to families, and kind of an overarching theme through all the systems, was this idea of trauma. So if people had not experienced trauma, if trauma was not something that came before their intersect with substance abuse or mental health services or any of the different child-serving agencies, it definitely became an issue after intersect. That's probably not the way it should be. So if you come in without trauma, but then you intersect with helping systems and you become traumatized, that seems to be a problem. So what happened was that we really talked about how we collectively need to understand that as families, we're not divided into these systems, but we may indeed intersect with these different systems at different points along our life journey. And all of those systems need to be trauma-informed, with the family at the center and the family guiding what needs to happen. So along our journey with the National Family Dialogue and working in partnership with literally, I think, I can't remember, and I think Sharon may be on the call, but I know that we had so many different pockets of excellence and different, not just individual family members, but also family organizations, small groups that had come together around the issue of substance use. And in our partnerships, we were learning a lot. One of the things that we were learning was about the CRAFT model, which is the Community Reinforcement and Family Training. And this was a model that was developed by Dr. Myers and Jane Smith of the University of New Mexico. It really is aimed at teaching families how to impact their loved ones while kind of avoiding both the up to now or up to then was really around detachment and confrontation. So many times parents were put in this position where they were told that in order to help their child, they needed to do tough love. They needed to either, you know, abandon their child, kick their child out, force them into situations that they may not want to do. All of those kinds of things were kind of the what parents were encouraged to do. And if they didn't do it, then they were seen as contributing to the problem, that they were codependent, which became a very bad word. They were also enabling. There was all this negative things about our very nature as parents to love and care about our children, right? And to not leave them when we saw that they were not doing well or ill. So this was a whole kind of shift, and the discussion became around the science of kindness and utilizing things like motivational interviewing and communication styles to actually create a different outcome. So the CRAFT model has proven to be effective in engaging those loved ones into treatment, and if not treatment, then decreasing their substance use. So what kind of is involved in the craft model is that it teaches families and friends, anybody who cares about or has somebody that they care about, some strategies for the loved ones to help themselves. And it's by changing the behavior and the way that we interact with family or the person who is working with the craft model. And it really it's all about when a loved one is abusing substances and is refusing to help, then this model really helps the families move their loved one toward treatment. And if not toward treatment, it helps their family to stabilize their situation while in the process of dealing with someone who is active in their addiction. And whether they engage in treatment or not, it really improves the lives of the families and friends and caretakers of those using substances or abusing substances. So it teaches things like, understanding what your loved one's triggers are. And I was looking at this morning and I was thinking, it also teaches us about how to identify our own triggers. Oftentimes, we as family members who have had a child with a substance use disorder are not often taken into account. Most of the treatment does not involve families, and if it does, let's just say an inpatient 90-day treatment program. You might get a weekend if you're lucky, but it doesn't talk about the trauma that those that love someone who is going through something like this experience. And what we found through the National Family Dialogue and all of the families that we're interacting with is that they have no place to go for their trauma and for their triggers, even long after their child may be on the path of recovery. So I'll give you an example. One of our family members says that she still, to this day, the minute her son comes to visit her, the first thing that she does is she picks up her purse and she puts it in her room and locks the door. And this is after a long period of non-substance use. So those triggers still remain of those experiences that we may have had because her son would steal money from her. So it teaches about those triggers, how to deal with those triggers, the communication and problem solving, self-care, and they say domestic violence precautions here, but I think it's more, at least from the craft model that I'm using, it's more about if you are in a partnership in parenting, then it really is how do you get on the same page around how you're addressing this. So the Center for Motivation and Change, it provides craft training and trains parent coaches, and there's a parent guide, and I'll talk about that a little bit later when we get to the resources. But they also provide the resources and support. So parent coaches are trained in the craft model, and then they offer peer support to assist families as they're dealing with the young adult substance use issues. And all parent coaches have lived experiences. So these are family members who have gone through something themselves around substance use disorders with their child and have that capacity to come from that place of lived experience. Their role is to listen with empathy and to support the family to problem solve, and then really to work with the family through the craft model and help them to kind of practice. So in order to become a parent coach, it's a 2.5-day training. It's based in the evidence-based principles of the craft model and motivational interviewing. And then there's the training, there was no, the expectation would be after the training as a trained coach that you would volunteer for 6 months. and that you would participate in some biweekly conference calls, and you could volunteer for longer than that. You can access the resources and other additional training, and I think they found that typically you spent about 3 to 5 hours per week. My experience being a coach is that at no point in time, if I did not have time or I wasn't in a place to be a coach in my own life, then there was no expectation that you do that. They're very, really about taking care of yourself. So they really went into partnership. The Center for Motivation and Change went into partnership with drugfree.org, and they have the resources for the parents and their allies. There's educational materials. There's a helpline, and then the parent and access to the parent coaches comes through the partnership for the drugfree.org. So I'm going to turn it over to Trish now. But before I do that, when Trish comes to completion, I'll come back full circle because I do want to say, talk a little bit about how this might potentially impact family-run organizations throughout the country and how they might start to tap into parent coaches and other expertise that is out there in order to provide services to those families affected by substance use. So thanks. Trish?
Thank you. Good afternoon, everybody. My name is Trish Todd, and I am with the Maryland Coalition of Families. And thank you very much for giving me the opportunity to come on this webinar and just give you a brief synopsis of how we have implemented our substance use program into our other navigation work. So today I really just want to give you a brief synopsis of who Maryland Coalition of Families is. Some people may know us, but in case you don't, we'll just tell you a little bit about us and really talk more about the development of our substance use program and some of the successes and challenges that we found while we were trying to implement that program. So MCF is, we've been doing family peer support since like 1999. And we started out primarily supporting families of children with mental health needs. Over the years, we've expanded that to include some substance use within the scope of our normal work. We've also supported families that have developmental disabilities in some cases, and we also saw that expand from children to the transition age youth population. So that's just sort of how it's evolved over the years. But all of our family peer support specialists, just like in the previous model, have that lived experience. So we've all cared for a child with mental health or substance use issues. That is just something that we have stayed pretty constant with, that we want to make sure that we have that lived experience so that we can engage and connect and understand what other families are going through. So for our substance use program, mainly as a result of the opioid crisis, in FY16, the state came to us and they said, that there was a lot of talk from parents. They didn't know where to go. They didn't know how to get started. They didn't know what they were dealing with in many cases with their children's addiction. So what we did, we got a planning grant in the first year. And we started partnering with the grassroots organizations. There was a lot of them, a lot of volunteer groups and family groups that were kind of bonding together and doing some support groups for themselves, just trying to figure out ways to connect to other people so that they didn't feel so alone. There was some advocacy organizations that were popping up that were trying to change things legislatively in the state to get like our Good Sam law passed and to make treatment resources more available to families. And then there was also foundations, because there was a lot of people that were experiencing very high costs in treatment providers, where they, $30,000 for a month to go to a treatment facility. So all those groups were sort of popping up and sort of in volunteer and some more formalized, but mostly volunteer groups. So what we did was we worked with those organizations, and we also engaged our community partners that we already were connected to, our health departments and core service agencies and such. And we ended up holding 10 focus groups across the state. And those focus groups were really just to talk to families. They had very, and I'll show you, there's a report that you can access on our website. But the report really has very little like data in it. What I find really helpful from it is that there's just a lot of comments from families. It's just really what they were telling us. So these were the questions we asked them. They were free to also volunteer other information, but we really wanted to know like what were the obstacles that they encountered, what was helping them, and what did they need. That was the most important. What do you need for somebody to help you? And what we found from that was that parents wanted they wanted more education in schools. They were like, why aren't our kids learning about this in schools? They wanted obviously more available treatment and detox beds. Currently, when we did this report or did these focus groups, families were waiting 5 and 6 weeks to get their loved ones into a treatment bed. There was lots of insurance concerns. They didn't understand what was covered, what wasn't covered, and I mentioned the exorbitant prices. There was a lot of HIPAA restrictions. If families did decide to self-pay, then they felt like, I'm paying this bill, but I can't get any information unless my loved one my child signs a release of information. So there was just a lot of trouble around that. The person would go into treatment and then they wouldn't hear from them or wouldn't know anything until they were released. They dealt with a lot of stigma, obviously, and they wanted to like a central place to go to get information. Like, who do they contact? How do they get where they need to go? How do they learn this stuff? So what came out of that was that really they wanted peer support. They wanted peer support for both the person that was experiencing the substance use and peer support for the family to help navigate that overburdened system. So after doing that in FY17, we were funded to begin a program. Obviously, our number one challenge was building that team and getting started on it. At near about the same time, we also implemented a Good Sam ambassador program where all of our family peer support specialists were actually going out and doing a public awareness campaign just to talk about the Good Sam law and trying to get people to make those calls so that they didn't let somebody overdose. So that was sort of simultaneous to our building this other program. But I came on first as the program manager, and basically, like I said, I had worked with MCF for about 7 years. I had been in a couple different positions with them, most of it being a family peer support specialist, and then also serving as family lead on a system of care grant at the very end. But the biggest reason was that my son experienced heroin addiction, and I think it was mentioned earlier that we really struggled back and forth between the mental health and the substance use systems. So I was really interested in making this better for people, and I actually was able to serve on some local integration committees and our state integration committee to help kind of move the system forward. But what we also did was we had one person that was in Baltimore City who was working on 2 small substance use projects. So she was essentially our second member of our team, and then we hired 5 part-time staff. And we knew Maryland's obviously not one of the biggest states in the country, but 5 part-time staff to tackle a problem this big we knew was going to be quite a challenge to reach out and connect everybody that we needed to. But we did hire people from those grassroots organizations, mainly because they had the experience, they had some connections in their community, and we knew that they could hit the ground running. And that was our objective, is really to get out there and start serving families as soon as we possibly could. So getting going on it. In building this, we were actually building it and implementing it at the same exact time. If you understand grants, then you know that that's kind of how that works. We knew a couple things we knew going in, that we wanted to stay with our practice model where we were serving caregivers, where we were working with the caregivers, and we knew that we wanted people to have that lived experience with substance use disorders. But there was a lot of other areas that we needed to consider too. It was questions like, was the work going to look the same? How did the work for our staff and their other organizations, how did they conflict or overlap? What we were doing, what could be incorporated? A couple of those areas were support groups. Some of those other support groups I mentioned earlier had already started up. They had pretty good attendance. They were well known in their communities. So we made the decision that since some of those family peer support specialists were also serving some of the families they were working with would be attending those groups, to incorporate those into our work as well. And then the other piece was advocacy. Some of the original 5 that started with us were very heavy in doing some advocacy work, and so this grant really did not include doing any of that type of work. Obviously, we're always trying to advocate for families and make sure their voices are heard and things like that, but this was really more on the legislative side. So we really had to move them away from that part, even though they still contribute to the overall information that we need, and we just funnel that through a different way. So some of the other questions were like, how were people going to contact us? We found that whereas a lot of the work we were doing before was in home visits or by phone, now we're doing a lot of work texting. We're getting a lot of texts. People contact us by Facebook. So that kind of brought up some privacy issues by how do we move people from the Facebook to contacting us directly. So that was an issue we had to face. Another area was that families that were coming to us now had kids that were in their 20s and 30s even. And we took a little bit of literary license, and our grant said that we were supporting families with young adults with substance use issues. So we said, well, if somebody was 70, somebody 30 was young. So that was, but we did find that, that we were hearing from people that had kids in their 50s even, grandparents raising grandkids, and just all sorts of people. So it really led us to truly offering a family support where we were including both the caregiver and the young person. A lot of them were young adults with their own rights and could make their own decisions, so it actually meant that we do come in contact with them more often. So one of the other areas we had to work through was our staff, helping them manage these dual relationships. Some of them, they had become friends with people that were experiencing this. They developed those relationships. They had connections to the young people themselves who, like I said, we were trying to stay with the model where we were really supporting the caregiver. Another thing, families were coming to us where normally we would get a referral and we would, or a family would contact us and we would go through this intake process that was, pretty much just finding out what they needed and all. We found these families were coming to us already in crisis. They are, very distraught. They know that, and I've been there myself, that when your kid needs to go to treatment and wants to go to treatment is a very, very small window. So it's just a necessity to get them there as quick as possible. So we were really dealing with a lot of people coming to us in that capacity. In some cases, our staff were working like case managers or crisis workers, interventionists, and that really wasn't where we saw their strength in supporting families. So it was about managing that relationship and helping them connect to those other resources that were appropriate for those types of services, and to keep them in the role of supporting the parent. finally, probably one of the hardest things that we've had to work through is that, MCF as a family support organization has been very much attuned to families losing their children through suicide, and we take that very seriously. But I don't think we were really prepared for the amount of family members that we would be losing and continue to be lost because of those overdose deaths. So we really had to think about, how do we continue to support those families? And we really were concerned with the secondary trauma to our staff. 4 of them had already lost their children to overdoses. So dealing with this type of ongoing trauma was just something we had to do. We had to make sure that they're definitely supported in that. So, so thinking about our program integration and our supervision, we decided we were doing implementing a regional supervision structure at the same time. So we sort of thought back and forth, is it better for the substance use team to sort of be their own little entity within MCF, or should we incorporate them into the structure the regional structure that we had set up? And we decided on the latter, and mainly that was because we knew that they would have the expertise of the supervisors that had been with MCF and had some of those connections in the community also. We wanted all of our staff to cross-learn, we wanted the mental health people to learn more about the substance use, and we wanted substance use to learn more about mental health. And we want them to be able to work collaboratively together. If a family comes to us and, maybe the primary concern is education of and behavioral health in the schools or something, then we wanted, but they, in the course of working with that family, find out that that's because the child's mother is addicted to drugs, then we want to support the grandmother in both of those areas. So that is sort of why we went with that structure. They have pretty much the same supervision guidelines as everybody else. We do have a monthly peer group with the regional team that's led by our clinical supervisor, and that is an area where they can share information about families and get supports and recommendations. We do a bi-monthly supervision, and that's in conjunction with myself and the supervisor. So during those times, we're talking about their schedules and the families that they may have, any administrative work that we need to cover. We're also talking about their outreach and the presentations that they do. This group is very good about, and they've been afforded a lot of opportunities to do some great outreach in our communities. So, so looking at what we sort of envisioned for that staff versus our existing staff, we thought they need the same competencies. We want them to know about peer and recovery supports. We want them to know about the communication. We want them to be, experienced in the crisis and the emergency and being culturally competent. So all of those things applied. So we just felt that the best structure for this group was to hold to our regional teams. As far as the training, one of the other things that we do with all of our staff is we have an intensive 5-day onboarding process. And that's where we're introducing them to systems of care. We're giving them some training on engagement, on communication, and then of course there's the regular administrative paperwork and all that kind of stuff that they're doing as well. Our materials for this group, we really had to start rethinking everything. We needed to change our language. We needed to make sure that we went from saying children to young person or young adult. We made sure that we were incorporating that. In our intake forms, we were asking about education, so now we found it was important to also ask about work and about secondary education because we were working with an older population as well. But that also included changing our surveys, all of our marketing materials, and we definitely engaged the team to help us, to help inform us in those areas.
Mm-hmm.
So one of the best ways to kind of tell you, I'll just give you a little example about how a family peer support specialist would work with a family is to kind of give you a story that was shared with us. We had a family, a mom that was, and her son, who was obviously addicted to drugs, and he was currently involved with an IOP program, intensive outpatient. He was also involved with probation, drug court. He did have a job, and he was having to make restitution. So anybody that knows that somebody is new to recovery, that sometimes having, I think we kind of think, let's just keep them busy and give them all kinds of things to do. But sometimes that can be really overwhelming to someone like that. But this young man was managing. So he did miss 2 IOP appointments. One was due to a doctor visit. The other was due he couldn't get off work. And he ended up getting notes for both of those events. So you would think, end of story, it's all taken care of, they were legit, and we know that sometimes people don't legitimately have something, or they're trying to get out of something, but this young man's excuses were legit. But the IOP provider was really holding tight to their protocol. You missed two appointments, you're out of the program, done. And the mother was just completely distraught. She was like, finally her son was making some progress, and he was doing the right thing, he was working, he was paying back the restitution, and then all of a sudden things were just sort of derailed. And she was really concerned because if it did go downhill, then she was afraid he would also start using again. So what our FPSS did was help the mom develop a plan, a communication plan, how she could talk to each of those people, make them all understand what was going on, and even help them come together. And what they ended up doing was realizing that by violating him, somebody who was doing the right thing, that was not the outcome that everybody wanted, was for him to be violated and potentially have a go back to jail, lose his job, and not be able to pay that back. So I think everybody realized finally that was the outcome that they really wanted, and the young man stayed in the program, so it all went really well. I think one of the biggest lessons that we've learned that I could share with you is that our staff, this work is really, really intense, and that our staff need to have a really strong support system. They're part of 2 teams, as I mentioned, the regional and the substance use team, and they really bonded well. They rely on each other, but as an organization, we know it's really important that we have to make sure there's procedures and resources and opportunities for them to debrief and share their concerns are all in place. At MCF, we use the analogy all the time of the oxygen mask, where when you get on the plane, you have to put the oxygen mask on yourself first to take care of yourself so that you can help other people. And so we really reinforce. I don't know how many times I tell the staff that. I'm continually reminding them of that. But overall, our funders have really found a lot of value in the work that we're doing. They did increase our funding for FY18, which allowed us to further develop the team. We ended up increasing the hours of the original team, and we're able to put on additional staff so that we can reach more families. And probably the most important thing is that families are always sharing with us that they are so glad to be able to connect to somebody who understands what they're going through and can help them navigate through that system. Thank you all very much.
Thanks, Trish. I think we're going to pass it back to Shannon, who's going to cover some recommendations and some resources that we have for you.
Thanks, Melissa, and thanks, Trish. I was so engaged in what you were saying, and I just wanted to kind of cement the point about how we need to really think about the families that are in those peer navigation positions or frontline workers, because they do come so many times. We come to this work because of our own pain, right? And, and we stay because we have a passion to see things be different. And then we're in roles where we're being exposed to kind of daily trauma with the families that we're interacting with. And so this issue around how we address secondary trauma with the staff and really the protocols around self-care, about both creating mechanisms within our organizations and our systems that promote self-care, but then also being able to know enough about compassion fatigue and other kinds of ways that that secondary trauma gets expressed, so that we can recognize them early on and begin to put some things in place that will help that, help those that are working, our staff, so that they can deal with the secondary trauma or have some avenues for self-care. So I just wanted to say that because it's so important. And many times in these conversations that we have, we talk about self-care and we talk about secondary trauma, but we talk about it at the end of anything that we're entering into. And I would like to strongly educate us so that we start talking about that in the beginning and really incorporate it through all different aspects of our work. So in terms of today and making some recommendations about next steps, I think it's just so critical that people just join the conversation. This is impacting all of us in different ways, and so we need, like I said before, we need to be part of the solution. And to listen to the families of what the families are saying. I didn't see the report that Trish had shared. I'm going to go back and look at it because my guess about that is that it will resonate with the things that we hear from families on a daily basis about what helps and what doesn't. And this idea of having someone kind of go through it with us, stand by our side, and help to point us in the right direction when we're overwhelmed is so important. And we have peer support providers out there in the world who are intersecting in all kinds of different ways and in all kinds of different mediums. So by that I mean we have our family peer support in the mental health arena, behavioral health arenas, and many times they're interacting with families, and maybe they're the frontline person that sees that there may be a substance use disorder, or maybe the family is actually asking about substance use disorders. And so we need to make sure that whatever avenues we're using to certify peer support providers, that they have an adequate process or adequate training in substance use disorders and ongoing training, because this is something that though our current epidemic is around the opioids, it certainly is not the only epidemic that we've gone through in terms of different substances, and so we need to be kind of constantly aware of that too and have the training and support that we need as peer support providers. We even see this, and I'll say how pervasive this is. So we even see this in the early childhood world with home visitors going into homes and working with families and not feeling like they have adequate information and supports in order to provide the assistance to the families. So I think we do need to develop some protocols and policies in our organizations about if we are going to be addressing or working with families with substance use disorders. And we have to address the stigma. And I say this because it's an interesting dynamic that even though we have stigma around mental health and we have stigma around substance use disorders, sometimes those stigmas get expressed very differently. And so while each of those behavioral health issues have stigma, because of the legalities and some developmental history around the particular disorder, the stigma has kind of evolved differently. And so I think while we need to address stigma in the general public around substance use disorders, we also sometimes need to address that stigma as it gets expressed in our family organizations. And that's kind of a tough thing to say, but it is a reality, and some families who have gone to family organizations that were born in the mental health field have felt like they have not been welcomed because they're coming in with a substance use disorder issue. So we need to think about how we can change that, how we need to, create an adaptive environment to change that. So we need to integrate into all of the work that we're doing those trauma-informed practices, and that sometimes will mean, of course, changing our language, but more importantly, changing our practices and the way that people are approached. There's many a family that have stood at the door of an emergency room with their child in danger and had to have the argument about whether this was a substance use disorder or a mental health disorder, and when in reality it was a life and death disorder. So we have to, really start to work about do the work we need to do to educate providers and each other about what it means to be trauma-informed and build a culture of compassion, and collaborate with non-traditional stakeholders. And what do I mean by that? I really mean that, sometimes our allies, sometimes we think that somebody's our enemy and they're actually our ally. So thinking about all the different places, initially when I was talking about not just different systems, but different places within our society. So, what are some of the non-traditional stakeholders? Many of our large employees need to have this conversation and need to have this education because of the lost hours that families spend dealing with substance use issues. So thinking beyond kind of what we would think of those within the behavioral health field or those within the substance use field, but really going beyond that. So, and I wanted to share, I talked earlier a little bit about the craft training, and I wanted to share in terms of where those resources were located. So if you go online and you look for community reinforcement and family training, you can actually find information on the evidence-based program. There's also a downloadable parents 20-minute guide. I would encourage you. This is just a tool. It certainly is not addressing everything that there is to address, but it is a very helpful tool that parents can use to help them start to think about how they might incorporate some of this within their craft training within their family. And then there's additional parent resources that they have available that are helpful. And then for us, the National Family Dialogue for Families of Youth with Substance Use Disorders, we also have resources. We have the ability to do some networking and to really connect you with others that may be working in a similar area around substance use disorders and providing support. And we continue to do that. We've done that with, actually worked with one state where we have brought the family voices together from mental health and substance use disorders to really begin to have the conversation, and now working together to create a cadre of coaches within that state so that they have the coaches for the craft model, parent coaches. And then the Partnership for Drug-Free-Kids.org, I would encourage anybody just to go in. They have excellent, excellent resources. They have the information about how substance abuse affects the brain, so the brain science is there. It is talked about in a way that's easily acceptable to a lay person who doesn't have to be a doctor or an academic in order to understand it. They have a ton of parent resources, and they have a national hotline. And that national hotline, if you wanted to get a coach or needed a coach, that's one way to access that is through the national hotline. We also have some different briefs that we've lined out here that are other kinds of information around what it looks like in the need for that cross-systems work. I think we kind of know that, but there's some evidence that we gathered around that. Just what it looks like right now in terms of family involvement in adolescent substance abuse systems. It is nowhere near has not reached the level that it has in other mental health and behavioral health arenas, and so we're working hard to increase that family involvement and create mechanisms and structures for that to express itself. So these are some of some additional resources, and I'm going to turn it over to Melissa to see if there's additional questions that we could open it up for discussion for a little bit here. Thanks.
Thank you, Shannon, and thank you, Trish. Thank you both so much. I think you both gave us some incredible information about CRAFT and the Parent Peer Support Program in Maryland. So much wonderful information to consider. And I think a lot of folks on the line have been asking questions as you guys have been presenting. So we want to spend the next 10, 15 minutes giving you guys an opportunity to respond to some of those questions. So the first question that came in, I think you may have answered, Shannon, but want to just give you an opportunity if there's anything else you want to add. The first question was, how do you become a parent coach in the CRAFT model?
So I think right now there is a listing of when trainings are going to be taking place, and you can find that in two places. You can find that at the Center for Motivation and Change on their website, and you can find that on drugfree.org.
All right. Thank you, Shannon. The second question for you guys is there was a question about what type of grant funded the planning year in Maryland that you talked about, Trish.
That was our funding actually comes through Behavioral Health System Baltimore, but it's a grant that's sent through our Behavioral Health Administration. So those are our primary funders for that.
Okay, thank you. We had another question around this, again, was something you talked about, Trish, in your presentation around how do you handle the privacy issues around communication through text and Facebook? Do you have protocols or policies, or how do you address that?
We have been trying to develop those. Basically what we do is we first try to get the family, explain to them that is not a secure method of contact. So that's the first thing. But we did develop a form that is it's a contact form, and it really talks about how we're able to, what is the primary way they want us to contact them. Is it through mail? Is it through phone? Or is it through email? And that making sure that they understand the risk if they were to contact us through Facebook. Most of the time, I think we try to tell people not to do that, and maybe they might contact us, but then we won't respond that way. We will actually contact them through the phone.
Okay, thank you. We had another question around, could you talk a little bit more about how you address the secondary trauma for staff and any protocols that you have for handling situations when there is a family member that passes?
Right. I mean, we're a relatively small team, so when that happens, we usually ask that they notify their supervisor and me at the same time, and then of course we take it, and inform our leadership team of that situation has occurred. We just, we try to be there to support the staff and the family in whichever way that they need us to. There really, unfortunately, is, at that point we're hooking them up to grief support groups and really trying to, help them just move through that situation and then following up with making sure that they're supported. And sometimes that might mean that they still continue with us for a while.
Okay. We have another question about...
Well, I guess I didn't really answer the secondary trauma piece, did I?
Go ahead.
So what we do with that is, and like I mentioned, because this work is so intense in those situations and just everyday things that we encounter, we try to make sure that they have a really close connection to their supervisor, to me, to our clinical supervisor, and support them in that way. We also have an employee assistance program that we encourage staff to utilize, and we really do a lot of work on wellness and taking care of yourself and making sure that you sort of have that ebb and flow, that if you have a really tough day, that maybe the next day you're trying to do something that's maybe a little bit lighter.
Okay, great. Thank you. We had a question around, does either program, either the Craft Model or your model in Maryland, train members on how to use Narcan to prevent overdose and to train families?
We do. I'm sorry. Go ahead, Shannon.
Go ahead, Trish. Go ahead.
We do. That was one of the first things that we did was we have actually 4 of our staff are trainers for Narcan administration. So we had them actually come in and train all of our family peer support specialists. We felt like no matter whether you were on the substance team or not, it was still important for you to, one, have the opportunity to be trained yourself, and if you did not feel like you needed to carry Narcan or whatever, that at least you could have that conversation about how important that is to families to make sure that they're trained.
Thank you. Shannon?
Yeah, I was just going to say the Craft Model doesn't specifically train in that, but we definitely can connect people to, the National Family Dialogue can connect people to Narcan trainings.
Okay, great. Thank you. We had another question around, is there an initial assessment for trauma and or vicarious trauma in your program? In either of the programs?
No, I'm not sure that that's something that, as family peer support, we would feel comfortable in assessing for. I mean, obviously we're putting those things in place to watch for it and to look for it, but we're probably going to, more suggest that either they seek help through another, or are you talking about with families or with our staff? Let me ask you that first.
I don't know. I think they're asking about with the families that you work with,
okay,
but I'm not sure.
Yeah.
Melody asked the question. Melody, if you want to type in the chat box which you're referring to as far as families.
Yeah, she's one for families.
Yep, she's,
right. So one of the things we definitely tell people is that we are not qualified to do any type of assessments for that. We know to recognize it, and we train staff to recognize that type of trauma, but not we would never presume to be able to assess someone for trauma.
Okay, great. Has there been any discussion about Medicaid potentially reimbursing for peer support using the CRAFT model? Shannon, do you know anything about that?
Yeah, this is Shannon. There has been discussion about that. I don't know where it's at right now, but there has definitely been discussion. And I think part of the challenge is really helping people to understand in terms of what is, because it's not focused on the primary, quote-unquote, primary client, but the family member, that makes it a little bit more challenging, although they are trying to include it in a cadre of things under recovery supports.
Okay. Thank you.
We'll keep paying attention to that to see where it goes. But I know there are people that are working at that. And I also know just, so I think it was Paul that asked that question. So Paul, I also know that one of the things that they've been talking about is, I know some of the healthcare provider organizations are looking at CRAFT, so the insurance kinds of folks that are looking at it and saying, is this something that, we really want to support? So the questions are being asked.
All right. Thank you. Sharon shared that family members who call the parent hotline speak with a professional social worker before they are assigned to a parent coach. So that must be for the CRAFT model.
Yes, if you're going to ask for a coach, to be coached, not to become a coach, but to be coached.
Okay. All right. Thank you for that clarification,
and
Sharon. And Shannon. Go ahead.
Yeah, just so folks know, too, the coaching model is not an ongoing coaching, so it's time limited and it's specific to coaching the parent or loved one around utilizing the coach model. So it's generally no more than 6 sessions.
Okay. Looks like we might have a couple of additional questions coming in the chat box. While we're waiting for those to come up, I wanted to just remind folks, if folks could, when we wrap up in a few moments, if folks could stay on the computer for just a couple of minutes, we have a brief survey that we ask folks to do at the end of the learning community. That just helps us get a sense of, was the information that was shared with you helpful, and if it helps inform future learning communities and activities that we provide. So if folks could do that at the conclusion of this presentation, we would appreciate that. I think we have gotten all of the questions answered. If somebody thinks of anything later that they'd like to ask, you can definitely reach out to us. We'll share contact information in a moment. We hope that you will plan to join us next month on April 19th at 3:30 p.m. Eastern Time. We'll be focused on ethics for parent peer support providers. During this learning community, we'll be sharing information about a workbook that FREDLA has developed for parent peer support providers and family-run organizations to address the many ethical dilemmas that can come up in your work as a peer support provider. So be on the lookout in the next week or so for emails containing the registration link for that event. And you can get signed up to join us on April 19th. And we want to thank you all for joining us today for the learning community. Trish and Shannon and my contact information are on this slide, as well as the website address for SAMHSA. So if you have specific questions or want to reach out for more information about either or both of the programs, you are able to. And if you are interested or in need of any training or technical assistance related to family engagement, family involvement, family-run organizations, or peer support, you're welcome to contact us at FREDLA as well. So again, thank you for joining us today, and we hope to see you next month.